Okay, hello, my name's Matt. I'm a Liverpool graduate, so I didn't do the same exams that you guys do, but I've been asked to try and give a lecture to you based on ECGs and Arrythmias. This will mainly be focused on interpreting ECGs and what they look like and how to interpret them. A little bit on the management, but if you want to know more about that, that's the kind of stuff you can read in textbooks quite easily, whereas trying to understand what they actually look like and mean is often easier done by being told about it rather than trying to work it out from paper. So basically we're going to have a quick look at trying to interpret 12-lead ECGs and basically look at ECG interpretation and some of the common arrhythmias that are associated with this. So this is the bit you all probably know. You start off with depolarization at the SA node, which leads to atrial depolarization and contraction, so you get the P wave at that point. Then the AV nodes depolarize during the PR interval, which you don't actually see on the ECG. This leads to ventricular depolarization and contraction in the QRS interval, main QRS wave, followed by repolarization as the T wave. As a result, you get something like that. I think you all agree that's kind of easy to interpret, and when you look in a textbook, that's what you're going to be looking at. When you get put on the boards, that's what you're going to get. And they're a bit more complicated, a bit more overwhelming. In fact, that's a really nice tracing, so that's quite a nice one if you get that on the board. To try and break down what you're looking at in the 12-lead ECG, it's important to try and know how an ECG actually works. So an ECG essentially is just showing you the electrical activity in relation to the leads that it's facing. If the electricity is going towards the lead, then you'll get a positive deflection. If it's going away from the lead, then you get a negative deflection. And that's basically the fundamentals of the ECG. As a result, anything that's going towards it will be positive. Things that are perpendicular to it don't really show very well and get a bit of a slow tracing, whilst things that are going away from it get quite a negative one. Based on this, anything that is anterior or inferior to the heart should give a relatively positive trace. Anything that's superior or posterior will give a negative trace, because that's how the electrical pathways are going through the heart from the sinoatrial node through to the ventricular apex. When you put that on the 12-lead ECG, you get the chest leads here. They're all mostly anterior to the heart, so they're all nicely positive. V6 is kind of to the side a bit, so that's almost a bit perpendicular, hence you get a bit of a smaller trace there compared to the other ones. When you're looking at the limb leads, as you'll notice, AVR is the complete opposite side, so you get a mostly negative trace over an AVR. Lead 2 is generally going along, the closest going along the septum of the heart. So this is the one we use for the rhythm lead at the bottom. When you're looking at these, 1, 2 and 3, they're all taking place at exactly the same time. So if you can see a P wave on one of those, then it means that there's a P wave on all of them, even if you can't necessarily see them. So you don't need to be finding everything in every single wave. And that's why they have this rhythm strip at the bottom, lead 2, and that usually gives the nicest trace. So if you can see things on that, then that means that you can find them elsewhere at the same time. Again, if you sort of try and move this physiology onto an abnormal ECG, here we have a picture of someone with left bundle branch block, and they've got the classic RSR wave. What's happening here is you're getting the ventricular depolarization of the right atriums happening quickly because the electricity is moving along the peduncle fibres. They conduct electricity really well, so you get a quick depolarization with that. As the fibres are blocked on the left-hand side, the electricity is having to go through the myocytes rather than along the normal conduction pathway. This is a lot slower process, so you get a second depolarization wave, which is the left ventricles now depolarizing. So that's why you get the RSR, because they're both depolarizing at separate times. With that, you can actually work out the sort of abnormal aspect of most ECGs if you kind of base it on how the investigation's actually conducted. When you're assessing the ECG, and as with all things, it's nice to have a sort of rhythmical approach. So assessing the patient first of all and foremost, followed by the rate, rhythm and axis, and then you can actually look at the nice morphology of it and try and interpret all the waves and squiggles. First of all, you want to assess the patient. An ECG only shows you the electrical activity of the heart. It gives you no indicator whatsoever about how well your patient is on the whole. So you can have two patients here, and based on this, the patient number 1, he looks relatively healthy. That looks like a normal sinus rhythm to me. Whereas the second one looks a bit abnormal. If you were just given them, you may be inclined to go and see the chap in patient 2 first. However, if you take it into clinical context, first guy might be having a cardiac arrest, have no cardiac output at all, and be in what we call pulseless electrical activity. Meanwhile, for the second chap, this is a normal ECG, and you don't really need to be that concerned. So you have to make sure that you're treating the patient, not the ECG. And this is true of almost all cases. You want to be doing an ABC approach, making sure your patient is stable, well and healthy, before you're getting bogged down with trying to work out what's going on with the investigations. Following that, you're looking at the rate. As most of you will know, small square is 0.04 seconds, large square 0.2. Way to calculate the rate, if you count 30 large squares, and that's 6 seconds, 6 times 10 is 60 seconds, so you can get the rate by counting the number of QRS complexes in 30 seconds. If you're impatient like me, then you can count out 2 large squares, times it by 30. The other way that people often do it's a bit quicker is dividing this number of large squares between the QRS complexes and dividing 300 by that. The flaw of this is that if it's an irregular rate, then that's not going to be a very accurate representation. Looking at the rhythm, sort of standards, you know, regular, 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 irregular, irregular, irregular. One of the ones that I never appreciated before starting work is this one here. That's a sinus arrhythmia, and that's just based on your breathing. When you inhale, your heart rate goes up as your heart's contracted by the lungs, constricted even. And then when you exhale, the blood's rushing into your lungs, so your heart rate goes down a bit. So you don't need to be worried about that, though I was at first. Looking at the axis, there's a huge degree of normal here. Apparently, normal axis is anything from -30 to +90 degrees, so the heart can really swing around quite a lot before you're getting concerned. To interpret this, you're using leads 1 and 3. As you may well know, left axis deviation, you're looking for a leading pattern, positive in leads 1, negative in lead 3. Whilst in right axis deviation, you're looking for this reaching pattern, negative in leads 1 and positive in lead 3. Causes of this, ventricular hypertrophy is the most common one. In the left axis deviation, you're also looking at inferior MIs. Right axis deviation, you can get right atrial enlargement, secondary to chronic lung disease, so cor pulmonale. And then we go on to the ECG itself. P waves, not really that exciting. You can get a bifid P wave, which will give you mitral stenosis, or just an enlarged one for P pulmonale. You can also be looking for absent P waves. Finally, we're getting on to something a little bit more interesting. Your handout will have all of these ECGs on them. The way that I found the easiest to learn these is if they have a picture of the ECG on one side and then what it is and sort of management of it on the other. Can anyone tell me what the top one is? So if you're looking at it from the start, does it look like it's regular in rate? Regular rhythm? No, it doesn't look very regular. Can you see any obvious P waves? No. So what are you thinking? Yeah. And then the second one, using the same kind of approach. That's also atrial fibrillation. AF, you can either have no P waves if it's very fine fibrillations, or you can have this kind of irregular pattern. Both are sort of the same thing. And the last one, atrial flutter. So atrial fibrillation, you're getting this continuous rapid fibrillations. Sometimes you can see it with this erratic behaviour. Sometimes you don't see any atrial activity whatsoever, you don't have P waves. Atrial flutter is caused by, there's this cycle of electricity going around and around in the atriums, but the AV node's a bit clever for that. So even though the atriums are trying to activate it every time, the AV node's having none of it, and they get what we call an AV block. So in this case, there's a 2-to-1 block, so there's 2 P waves for every QRS complex. The danger here is when they don't have an AV block, and then they can get really tachycardic. Management of these, you're looking to see if it's new or chronic. If it's chronic, then they've probably got an underlying cause known, and you can try and manage that a bit better. For atrial fibrillation, they do speak of the curative treatment of DC cardioversion. This isn't as exciting as you may sort of think. They don't jump in and try and put the paddles on straight away. It's usually an elective procedure done a few weeks after the diagnosis. So if you're asked about the management with a patient on the wards, then that probably won't be your first option. They can also be rate or rhythm controlled. A lot of them end up in beta blockers and the elderly ones digoxin. An important thing to consider is anticoagulation. Have you heard of the chance 2 score? So C is H, hypertension. A, what's the age? 75, yeah. Where are we? D, yeah, and S, yeah, and that gets 2 points because that one's super important. If it's a score of 1, then you want to be starting them with aspirin, and if it's a score of 2 or more, you want to be warfarinizing them. Atrial flutters generally sort of managed the same way in the long term. However, acutely, if they're going really tachycardic, then you want to be doing your Valsalva and carotid sinus massage, the vagal maneuvers, and maybe giving adenosine. When I was a student, I used to get adenosine and atropine confused quite often. If you try and, atropine is a little bit of QI knowledge for you. Atropine is named after the Greek goddess of Atros, who was insanely beautiful apparently. So when anyone saw her, their heart rate went sky high when they got very excited. So if you give someone atropine, you're going to increase their heart rate, so you give it to anyone with bradycardia. Adenosine is the one that does the complete opposite, the impending doom. And it is quite horrific when you give it, because you do get a flat line for a good few seconds, and you're praying that you'll see a little blip on the screen, and then eventually it does come on, but the heart rate's 20 or something rubbish like that. But eventually it does come back around. Curative treatment, atrial flutter, they can actually try and find this accessory pathway, and then they can ablate it, and then that will get rid of the flutter, hopefully. Okay, moving on. PR interval, normally 3 to 5 squares. These are sort of the main abnormalities we're looking at here. Anyone work out what the first one is? Heart block, 2 to 1. That's actually, it's complete heart block, that one. If you're looking in the ventricular and the atrial rates are actually regular, they're just not correlating to each other at all. The second one, what is the second one? Okay, the second one is your 2 to 1 heart block, that's Mobitz type 2. And the third one, that's the Mobitz type 1, where you're getting progressive prolongation of the PR interval before one's dropped off and just not exciting the AV node. And then the final one is your first degree heart block. The first degree heart block is due to slow conduction in the AV node, rarely symptomatic, and it's nothing that the cardiologists really get very excited about. Doesn't usually require intervention or follow-up. Second degree heart block, you've got Mobitz type 1, which is also winky back. And here, as I said, you've got the progressive PR prolongation until a P wave fails to conduct and you don't get a QRS complex. This is due to a block in the AV node, but it usually only requires monitoring because the risk of anything sinister developing is low. Mobitz type 2, on the other hand, here P waves are regularly failing to conduct, and there's usually a block in the His bundle. This is a bit more complicated. The risk of heart block, complete heart block and asystole are considerably higher. So these people usually require referral to cardiology and a pacemaker. Complete heart block is when all atrial activity is failing to conduct into the ventricles. So as I said, you've got regular PEPs, you've got regular QRS complexes, but they're not correlating at all. They can have different rates, and that's dangerous. So they usually need a pacemaker, dual chamber one, so that it will excite the atria and the ventricles at the same time. Moving on to the QRS complexes and bundle branch block. As we kind of discussed at the start, here you're getting a fast activation through as the electricity is going through the normal pathway, followed by a slow one as it's going through the myocytes. So you get these double waves. Oh, and I thought I'd block them out. But you've got left bundle branch block on the left-hand side here, where it's got, oh, it blocks out afterwards. Sorry about that. So William Marrow, you may have heard of him, he's generally quite a famous chap in cardiology, quite popular. You're getting the M wave in V6 area, W in V1 and left bundle branch block. Right bundle branch block, you've got the W in V6 and the M in V1. You don't have to have both the W and the M. Usually you only see one. I don't know if it's because I have selective vision, but usually I see the M's easier than I see the W's. Your differentials for these, left bundle branch block, the scare is this new? If it's a new left bundle branch block, then you're likely to have some sort of ischemic heart disease going on here. And they'll need your restriction, your MONA, treatment for any sort of ischemic heart disease. You need to get in touch with a cardiologist, they may need PPCI or some sort of definitive treatment there. Other causes, if it's more chronic, hypertension, cardiomyopathy, aortic valve disease. Right bundle branch block can be normal. 1% of the young population have it, which means one person in this room probably has it. Again, it can be caused by coronary artery disease, cor pulmonale, or congenital heart disease. Moving on to the more complicated ones. Narrow complex tachycardias. And these all can appear quite similar on an ECG, generally because they've got quite a fast ventricular rate. You can try and slow down the rate on your ECG machine. I'm not quite sure how you do it, but then it sort of prolongs everything out. So instead of the squares equaling 0.4 seconds for a large one, you can make it so that they equal 0.2 or whatever, and then you can have a better look at things. Here you're talking mostly about AV, NRTA and AVRT. Okay, so atrial ventricular nodal re-entry tachycardia. That's this one here. So like atrial flutter, you've got the electricity going through the atria quite happily, but unfortunately it's conducting through every time. So here you've got a rapid heart rate, and the P waves either disappear as they are in the first one, that's been slowed down though to make it easier to see, or in the second one the P wave is almost looking like the T wave because it's just catching up so quickly and your heart rate's too quick. The second one, atrioventricular reciprocating tachycardia, which is Wolff Parkinson's White if it's symptomatic. Here you're getting the delta waves. This is because you've got this accessory pathway going through here. So the accessory pathway, for reasons unknown to me at least, has very high conduction rate. So you're getting the ventricles are conducted very quickly through the accessory pathway, but they're also conducted through the normal pathway in the middle. So you start getting this depolarization quicker with this bit of the delta wave there, but then the rest of it's getting activated with the actual normal conduction, so it's going through here. So that's why you get this swooping delta wave, because it's getting activated in the same way, but at different speeds. I don't know if that makes sense, but yeah. There you go, so short PR intervals and the delta waves. These are managed with the vagal maneuvers, so you've got Valsalva, does anyone know what that is? Valsalva one? That's one where you're sort of trying to puff her out. So what they typically do is you get a syringe, just a big one of 20 mils or 50 mils, and try and blow you and push the top out of it. By doing that, you're sort of compressing on the heart, like you were the sinus arrhythmia, compressing the heart, slowing the heart rate. You can also do the carotid sinus massage, which I've never seen attempted. I'm not really sure how it works, or if it works, I should say. Again, you can use adenosine, and curative, you're going for the cardiac ablation. In these ones, you also want to consider atrial flutter and atrial fibrillation, because they can also cause significant tachycardias. And these problems are often presenting in younger patients who are otherwise fit and well and have no history of cardiac disease. Finally, you've got your broad complex tachycardias, and these are bad. You don't want to see these. If you do, then you're probably wanting senior help really quite quickly. you've got your tachycardia and your fibrillation with ventricular, and they're likely going to need DC shock. So if I were you, I would be doing your ABCD, again making sure that airway is competent, etc. Calling for a senior review, and in the meantime you can probably get the crash trolley ready and put the paddle on, because that's not going to end well on its own. After that you've got the ST segment. So here you're looking for the J waves. The J wave is this portion in between, actually in the ST segment, and here the main thing we're looking at is STEMIs. As you probably know, 2 millimeters or more in the chest lead, 1 millimeter more in the limb lead, and as we've already discussed, new left bundle branch block. These are all sort of definitions of STEMIs. For your management, as you may know, you've got MONA, morphine, oxygen, nitrates, and aspirin. And then you want to be contacting the cardiologist. These days a lot of people get PPCI if they are outside hospital, but I've never seen anyone rush down for one in hospital yet. By looking at the 12-lead ECG, you can try and work out where the MI is. And this is where things get a bit more complicated. So here, as we said beforehand, the chest leads are looking mostly at the anterior portion of the patient's heart. So these blue ones, V1 to V3, some people say V2 to V4, they're indicating an anterior MI, so that will be the right coronary artery. The yellow ones, particularly you're looking at V5, V6, AVL, a bit of one, and this is a lateral MI, so here you're looking at the anterior descending artery. And whilst the red ones, 2, 3 and AVF, they're sort of inferior to the heart, so that's looking at an inferior MI. Which is generally a little bit milder. You can't put a specific artery to it. And additionally, if you see depression in V3, V4, then that's what we call a posterior MI. What you can do is you can try and put the leads on the sort of reciprocated position. So if you put the leads on the back, then you get a negative tracing, and then you're looking for ST elevation. That's a bit complex, and you'll probably have to get a cardiologist or ECG technician to talk me through that for the exact location of each of the leads, but apparently it is possible. That picture, apparently all these slides are going online, so you should be able to get that. You can also Google it to try and find it, but it's actually a bit more difficult to find than you think. Finally, at the end of the ECG, you've got your T wave, which is often sort of forgotten about. No one really looks at it that much. If it's peaked or flattened, you're looking at hyper or hypokalemia. And inverted, it's a MI but not full thickness, so this could be an MI that's happened a while back and it's repaired a bit, or maybe it's just not as severe. As with all these things, so just a tip about being an F1 rather than anything to do with ECGs, if a nurse bleeps you and they're calling you because the patient's potassium is 6.2 or whatever, rather than saying, okay, I'll be there, put down the phone, and running over, there are things that you can get the staff there to be doing. So you can ask them, can anyone there do an ECG and get that going. You can ask them if the patient's ever had a high potassium in the past, or just for the patient's name, look that up yourself. And again, as we were discussing at the very start, sort of the status of the patient is much more important. So they're all, are they tachycardic, is their blood pressure stable? Rather than running and trying to save the day yourself, there's actually a bit of a team on these wards, which you don't realise for quite some time, at least I didn't. So if you can get other people involved, then they feel good and it makes your job easier. And that's it. Oh, and finally, that last ECG is bad. You want to avoid that one. And always check that you've got the leads on properly, because you can get asystole without having the leads on, and that goes over a fry. There you go, that's the basics of ECGs.